Okay, in this video, we will be discussing about mitral stenosis. We know that mitral stenosis is a valvular heart disease involving the mitral valve. Basically, it is, tightening of mitral valve, right? Mitral valve is a three-dimensional valve. A few things about the anatomy. Mitral valve is a three-dimensional valve. Its anatomy is very complex as compared to tricuspid valve. Although tricuspid valve is has have three, tricuspid valve has three leaflets, but the anatomy of tricuspid valve is a bit easier. Mitral valve, as well as surgery point of view is concerned, mitral valve is a very complex in its anatomy. It has five components. First is leaflets. There are two leaflets. One is anterior, other is posterior. There are two commissures, anterolateral, posteromedial, annulus, chordae tendineae, and papillary muscles. All these components make up the mitral valve. What is the etiology of rheumatic heart disease or etiology of mitral stenosis? Rheumatic heart disease is nothing but mitral stenosis. Anywhere in medicine or in cardiology, wherever there is term rheumatic heart disease, it is mitral stenosis, because the cause of mitral stenosis is RST, 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 rheumatic always. Though it is written in the books that 95% of the cases of MS are due to RST, but uh, in practice, what we see, the 100% cases of MS are due to rheumatic heart disease. How rheumatic heart disease develops? Rheumatic heart disease is nothing but MS, right? Acute rheumatic fever is different from RST. Acute rheumatic fever with carditis will develop onto rheumatic heart disease, right? 40% of ARF with carditis over a period of 15 to 20 years will develop rheumatic heart disease. How rheumatic heart disease presents? Most common presentation is MS plus MR. See, alone MS is not a presentation of rheumatic heart disease. It always presents MS and MR in combination. And second most common presentation is MS plus AR. And third is the AS plus AR. Right? So these are the presentations of rheumatic heart disease. How does it develop? What is the pathology? See, chronic inflammation of leaflets. We need not go into details of molecular mimicry of group A beta hemolytic streptococcus, but we have to we have to know the crux of the pathology. That is, there is chronic inflammation of leaflets because of some throat infection in the past, which will cause commissural fusion. Why? Chronic inflammation will cause edema, and it will cause more friability of the walls and the zone of coaptation. I mean, it will be inflamed, and the commissures will fuse. And at the same time, there is inflammation of the chordae tendineae also. They will also fuse and they will shorten, and the further calcification of the stenosed valves will give the typical fish mouth appearance of the mitral valve. This is the pathology. How the leaflets, they fail to open completely, how the leaflets, they become sticky and they become very stenosed. It is because of chronic inflammation per se. Now, according to AHA guidelines, right? Previously, the classification or the severity of MS was a bit different. Now, from last 2 3 years, there is new guidelines, new AHA guidelines for the severity of MS. Right, severity of MS. We have to classify the MS into three categories. First is the progressive. Second is severe but asymptomatic. Right. Third is severe and symptomatic MS. These are the three severity classes of mitral stenosis. How are they classified? They are classified on the basis of valve area and a few other parameters which are not being discussed here. One is the flow gradient or LVEDP, I mean echocardiographic parameters, but we will be focusing on the valve area only for easy understanding and easy learning of the severity of MS. Progressive MS is when the valve area is more than 1.5 centimeter square. Severe but asymptomatic is when the valve is less than 1.5 centimeter square, no symptoms, right? No symptoms. Severe but symptomatic MS is the valve area is same, less than 1.5 centimeter square, but there are symptoms. So these are the progressive, severe asymptomatic, and severe symptomatic MS. That is the severity of MS. Now, how the hemodynamics they change in mitral stenosis? See, whenever we do echo or whenever echocardiographically we try to look onto the anatomy of the valves or the function of the heart per se, what we always try to know is left ventricular and diastolic pressure, because it is equal to LVEDP is equal to left atrial pressure, and left atrial pressure is equal to pulmonary capillary wedge pressure, and pulmonary capillary wedge pressure is equal to pulmonary artery and diastolic pressure, right? These all pressures are equal. Now, because there is mitral stenosis, suppose this is the left atrium and this is the left ventricle. This is the left atrium, this is the left ventricle. Because of the stenosis of the mitral valve, the blood doesn't flow from left atrium to left ventricle. See, so that is why left atrial pressure has to increase in order to fill the left ventricle. If left atrial pressure will increase, LAP increases, pulmonary capillary wedge pressure will increase, pulmonary artery and diastolic pressure will increase, left ventricle and diastolic will also increase, right? That will cause LAP is LAP and PCWP, they will increase, and what will they cause? They will cause dyspnea on exertion if the case is mild, and they will cause dyspnea at rest if the case is severe. Right, these pressures are responsible for dyspnea on exertion or dyspnea per se. Right, left atrial pressure increases and pulmonary capillary wedge pressure increase. These are the two hemodynamic points that we need to remember. Signs and symptoms of mitral stenosis. First is the dyspnea on exertion, mild MS. Second is dyspnea at rest, severe MS. Third is the pulmonary hypertension. That is, we will hear loud P2. Right heart failure. The signs are hepatomegaly, ascites, and edema. Right. Impending right heart failure, we have to look for hepatojugular reflex. That is, it has to be sustained. Sustained hepatojugular reflex. Right. It is not reflex, it is reflux. Right. Then JVP. We will see two waves. First is the A wave because of right ventricular hypertrophy. Second is the V wave. V wave is because of tricuspid regurgitation. Right. So these two waves will be visible on JVP. Then next is the orthopnea and PND. These are the other uh, features or other signs that we will see. Now, what we see on what we hear on auscultation, what do we listen to? First is there will be loud S1. Why loud S1? Because LAP increases, it will push the leaflets, mitral leaflets far away. Then when LV contracts, leaflets close with more speed. That will cause loud S1. But at the same time, if the leaflets are calcified, there will be soft S1. This is an exception in in mitral stenosis. When the leaflets are calcified, the S1 will be soft. Then there will be loud P2. Why loud P2? Because of increased pulmonary artery pressure or pulmonary hypertension. Pulmonary artery pressure or pulmonary hypertension. Right? Why? Because PCWP increases. And if it remains elevated for longer periods of time, it will cause pulmonary vascular remodeling, and it will cause pulmonary hypertension, and it will increase pulmonary artery pressure, which will cause loud P2. Third is the opening snap. See, when LA contracts, the stenosed mitral leaflets, they open with a force and they open with a certain click, that is opening snap, that is clicky sound. Third is the pre-systolic accentuation. Because of stenosed mitral valves, the filling of left ventricle is not that complete. So the left atrium, it contracts with force to cause pre-systolic accentuation of the murmur. Pre-systolic accentuation of mid-diastolic murmur of MS. That is the complete auscultation finding. Then there will be then there is a correlation between the duration of murmur and the severity of MS, not murmur, severity of MS, right? Longer the duration of murmur, more is the severity of MS. That is a must know point, must remember point. Associated murmurs. See, whenever there is mitral stenosis, long-standing mitral stenosis will cause tricuspid regurgitation. It can cause pulmonary regurgitation also because of elevated right-sided pressures. When there is tricuspid regurgitation associated with MS, it is known as Carvalho sign. Where will it be audible? It will be audible in the right sternal border. Then pulmonary regurgitation. It is also a diastolic murmur. It is known as Graham-Steele murmur. Pulmonary regurgitation, the murmur of pulmonary regurgitation, known as Graham-Steele murmur. Right. How do we investigate the patient? First of all, we will do chest X-ray because the patient will come to us with dyspnea on exertion or dyspnea at rest. What we will see on chest X-ray PA view, we will see the straightening of left heart border, which is obviously a very important sign of mitral stenosis because of left atrial enlargement, right? Then there will be impingement of esophagus on lateral view of chest X-ray. There will be splaying of carina because of elevation of left main bronchus by increased or enlarged enlarged left atrium, right? On echo, basically we do echo to look at the mitral leaflets, to look at the anatomy of mitral leaflets, and secondly to rule out if there is any mass in the left atrium. So it rules out left atrial myxoma, transthoracic echo basically. So remember, in case of left atrial thrombus, we do transesophageal echo, which is more sensitive. But otherwise, in a simple case of mitral stenosis, we will do transthoracic echo first of all. Then there will be ECG. We will see left atrial enlargement, which will be visible as P mitral in lead 2, right? P mitral in lead 2. That is P mitral M-shaped P wave we will see in lead 2. So these are the three main investigations for the purpose of diagnosis of mitral stenosis. How do you treat a case of mitral stenosis? See, there are four things which we need to remember. Four treatment options which we always need to remember as far as treatment of mitral stenosis is concerned. First is TMBV, that is percutaneous mitral balloon valvotomy, also known as commissurotomy. Right. Second is the mitral valve replacement. It is a surgical procedure. It is basically an angiographic procedure. Angiographic approach is used in this. Then third is a vitamin K antagonist. If there is atrial fibrillation, we use warfarin with a target INR of 2 to 3. No role of novel oral anticoagulant like dabigatran, apixaban, edoxaban, rivaroxaban in case of valvular AF. Right? In valvular AF, we use warfarin only. Warfarin only. No role of NOACs. This is a flowchart from the Harrison's for the treatment of which shows us the treatment of rheumatic mitral stenosis. The treatment depends on the severity of MS. If the valvular area is less than 1.5 centimeter square, we have to see if the patient is symptomatic and valve is pliable. We do commissurotomy, right? If the patient is asymptomatic and the valve is pliable and the artery are systolic, this is some echocardiographic finding, some systolic pressure. If it is more than 50, we will do commissurotomy. The level of evidence is 2A. I mean, we have to do commissurotomy. It is more benefit than harm. If the mitral stenosis is progressive, right, it is not severe, it is progressive only, but the patient is symptomatic on exertion symptoms, and hemodynamically significant MS is there, valve is pliable, we can do commissurotomy, right? We can do commissurotomy. So this is basically the treatment algorithm for rheumatic mitral stenosis. We have to, first of all, we have to look for the severity. If more severe, we will go to commissurotomy. If the patient is progressive but not severe and the patient has exertion symptoms, we can do commissurotomy. So that is all about the treatment of atrial fibrillation. And the video of the video of basically mitral stenosis is complete. I believe you must have learned a few things. That is all about MS. Thank you for your patient listening.